Hello and welcome. Thank you for taking the time to join us virtually today. I'm Joanne Fitzgerald, Executive Director of Hospital Policy and Classification at IHPA, and for this week I'm also Acting CEO. Before we start the webinar, I'd like to acknowledge the traditional custodians of the many lands on which we're meeting today. For me in Sydney, that's the Gadigal people of the Eora Nation, and I recognise their continuing connection to land, water and culture. I pay my respect to elders today and those who walk in spirit. Well, it's great to be back for our second Q&A webinar for 2022 and also the second last in this series. Since we launched the series mid last year, we've hosted bi-monthly sessions that cover each of the core functions that IHPA undertakes in order to determine the national efficient price for public hospital services. So cover topics such as policy development, the safety and quality work, classification development, costing and data collection. And if you missed any of those earlier webinars or simply want to watch them again, they are available on our YouTube channel for viewing. And they also do for the topic for today's webinar, which brings together all of those areas as we focus on pricing itself. With the recent release of the National Efficient Price and National Efficient Cost determinations for 2022-23, the team is eager to engage with you on the process for calculating the Commonwealth funding contribution for public hospital services, so you can better understand how this relates to your area of work. And we've got IHPA's senior leaders and the technical advisors who are responsible for undertaking this work on the panel, and I'll leave our moderator Trent Yin to introduce them shortly. If you've joined us for these sessions before, then you know we jump straight to the questions, the Q&A, assuming obviously that you've hopefully all watched the pre-recording with Dr. Sarah Neville and Dr. Sam Webster. So we will jump straight into questions, and feel free to start entering your questions in the live Q&A panel at the moment. I look forward to following the discussion today. I would like to introduce our moderator for today, Dr. Trent Yin, who is IHPA's Senior Data Scientist and an Honorary Senior Research Fellow at Macquarie University. Dr. Yind has a PhD in mathematics and over 15 years experience in advanced data analytics, statistical modelling and policy advice in the public sector and in academia. Trent has been with IHPA since its establishment in 2011, and his roles have included leading the technical development of IHPA's national pricing models and several of the classification systems that IHPA maintains. His interests include the use of data to interpret physical systems, solve problems and innovate. I hope you enjoy the session today, and also hope to see you for the final webinar session in June. But let me hand over to Trent to introduce the panel. Thanks, Trent.
Good afternoon and welcome to the 6th instalment of the Independent Hospital Pricing Authority live Q&A webinar series. Today's session is titled Fair and Responsive Pricing, Determining a Nationally Consistent Approach to Funding Australian Public Hospital Services. The session will focus on the pricing of public hospital services for Australia's National Activity-Based Funding System, and in particular the annual determination of the National Efficient Price and the National Efficient Cost. The National Activity-Based Funding System has been 2012 under the National Health Reform Agreement and is used for determining the growth in public hospital funding from the Australian Government to states and territories, and for the distribution of this funding to each jurisdiction's local hospital networks. You can find a really useful overview of the role of IHPA in activity-based funding and the national pricing model, as well as the national benchmarking portal, in our introductory presentation available on IHPA's YouTube channel. The purpose of today's session is to provide you, the audience, with the opportunity to engage directly with our panelists who share an extensive knowledge on these topics. We have around 50 minutes to take your questions, which I encourage you to post via the Q&A widget in your browser window. You can also upvote other audience questions that are of interest to you. Let me now introduce the three IHPA panelists that are joining us today. So to begin with, we have Professor Kees van Gool, Executive Director of Pricing and Funding. Kees leads the team responsible for the pricing and funding functions undertaken by the agency. Kees joins IHPA from the University of Technology, Sydney, where he was Deputy Director, Centre for Health Economics Research and Evaluation, and Chief Investigator of the Centre for Research Excellence on Value-Based Payments in Cancer Care. He brings his extensive experience in international, national and regional health policy research and quantitative skills in microeconomic modelling and linked data uses. Our next panelist is Dr. Sarah Neville, Director of Analytics and 2021-22 Harkness Fellow in Healthcare Policy and Practice. Sarah is a statistician with a strong interest in health research and leadership in the Australian year, setting price for hospital services in order to make hospital funding more transparent and equitable. Prior to this, she completed a PhD in mathematical statistics, and her interests lie in health funding systems, Bayesian statistics, and women in STEM leadership. Sarah is passionate about the power of statistics to inform evidence-based policy, both in Australia and internationally. And our third panelist is Dr. Samuel Webster, Director of Pricing. Sam leads a team of mathematicians and statisticians to develop the pricing models for the National Efficient Price and the National Efficient Cost determinations. Sam has been at IHPA for 8 years, where he's worked directly in prospective cost modelling and in admitted acute care and predictive cost modelling for small rural hospitals. As director, he has led the implementation of safety and quality pricing for hospital-acquired complications, avoidable hospital readmissions, and most recently, pricing admitted mental health care services. And prior to his role at IHPA, Sam was a pure mathematics research and teaching academic at the University of Wollongong. So welcome to our panelists. While we wait for the live questions to start coming through, I might begin with a few of my own I have here. So to kick things off, let's ask a COVID question. I'm sure it's on everyone's mind. So what measures does IHPA have in place to account for the short-term and long-term impacts of COVID-19 on the hospital system and how these impacts may vary across jurisdictions? Who wants to open up?
Alrighty, I guess I can say a few words on that. So, g'day, I'm Sam. We did quite a lot of work on analysing and understanding data from before the onset of the COVID-19 pandemic, as well as after the onset, so in the first few months of 2020, and through very extensive consultation with our stakeholder groups, which are predominantly state and territory representatives, as well as the Commonwealth. We developed a set of assumptions about the initial impacts and future of COVID, so around what the impacts on hospital activity would be and what the expected short-term impacts on costs would be, as well as the long-term impacts on those costs. And so from there, use our extensive data collections to estimate, within these assumptions that we made, to estimate the initial step change in cost that would be due to the onset of COVID. So this is, for example, increases in cleaning and screening activities in hospital, etc., and as well as like the increases in input costs for care. And as well as that, we're able to statistically, I guess, isolate that impact to measure what the long cost growth would be for forecasting costs into the future.
And how about well, I mean, I wonder about activity and the role hospital activity plays in all of that as well.
So there was, we did, as you'd expect, on the onset of the COVID pandemic and coming into lockdown, a lot of states and territories and areas going into lockdown, we did notice a very sharp decrease, or a very significant decrease in hospital activity, and we're able to use that to understand like how that affected the the unit cost in a hospital. So obviously, when a hospital's not operating at capacity, it's not as efficient for a hospital to be delivering services, and we designed the pricing model for future years with that in mind to try and account for that.
Yeah, and just to add to that, is that I think one of the analytical challenges that that IHPA has, and something that I've been acutely aware of since joining the group, is that of course we're basing in this case, the NEP for 2022, which gets implemented over 22-23, on 2019-2020 cost data and activity data. And so one of the challenges for NEP 22 was, of course, that in that period, it was only the last 3 months of that period that were impacted by COVID. And as we move forward into the next round for NEP 22, 23, 24, we will have more up-to-date data from 2020, which will reveal a lot more of the impact that COVID has had. And so there'll be future analytical challenges which we are working with jurisdiction on to try and grapple with for the next round.
Okay, so I might just ask a question on a different topic, on value of care, so on high or low value care. So has IHPA considered introducing price incentives or disincentives, such as for high or low value care, or for new technologies that have been demonstrated as cost effective?
Yes. I can probably say a couple of words on this as well. And I'm not sure if it'll really address the core of the question, but from the perspective of price modelling for public hospital services, so there are some incentives built into the pricing currently. So, for example, there are incentives around length of stay, so to try and keep length of stays as short as reasonably possible. And when I say reasonably possible, that's based on typical length of stay profiles we see around the country. But there is also recognition that, there may be good clinical reasons there are definitely good clinical reasons in a lot of cases for hospital inpatient stays to extend over a much, greater length of time than the average length of stay. And in those cases, there are additional per day payments, so that those episodes aren't unfairly penalised by the structure of the pricing models. From the new technology point of view, so there are a number of approaches we have, or a number of frameworks we have around accounting for new technology. So first and foremost, and would be the new technology pricing framework. I hope I got the name of that right. I think it changed names maybe recently, but we do hold public consultations and clinical particularly with clinical experts around the use and recognition of new technologies, and that will inform in the first instance our classification development. So where new technologies are being rolled out and picked up in public hospitals, that will be reflected in our classifications, which will ultimately be reflected in prices that are set. And then there's to the side of that, I guess there's new technologies, so like highly specialized therapies such as the CAR T-cell therapy is one that comes to mind, which was recently, within the past couple of years, announced as like the Commonwealth government would fund a significant portion of that and approved it as a therapy in Australia. And so we do work with states and territories to understand the costs and also the amount of accessing those very highly specialised, highly costly therapies, and determine block funding amounts associated with them. Does that broadly cover it, or Sarah or Kees, would you like to add any more to that?
I might just add, so Sam sort of spoken about current incentives that are built into the pricing models. I might just speak a little bit about some of the future work that IHPA is considering in terms of value-based care and considering the move from activity-based funding, which is all about volume, with some quality incentives built in, such as the funding adjustments for hospital-acquired complications and avoidable hospital readmissions. We're also investigating areas where different funding methodologies such as bundled payments or capitation payments might be able to fit into the ABF framework as sort of, carving out particular care pathways that might be amenable to a bundled payment that would cover multiple streams of care. So, for example, joint replacements, you might have an element for the acute surgery, but bundle that in with follow-up outpatient visits. So IHPA's put together a future funding models framework that we've consulted with all health ministers on, and we're looking to work with jurisdictions to pilot programs that jurisdictions are interested in looking at whether a bundled payment system or a capitation payment system might be workable, and testing that out by implementing that through a pilot before.
I might just add a little bit to that, Sarah. So just for any viewers that aren't so familiar with bundled or capitation payment system, so the idea around these payment systems is, as opposed to ABF, for example, is that with ABF, where each service would be paid for, so for example, the surgery and follow-up post-operative visits, etc. Within ABF, it's a per service payment, and having the bundled payment, which Sarah was talking about, allows flexibility at the state and hospital level. They know they'll get, it allows them to trial and, have some flexibility with what they can spend that on, and, that to use, maybe there's variations in that pathway of care. So I just thought I'd add that, and similar for capitation payments as well.
And it gives me just a great opportunity to just foreshadow next webinar number 7 at the end of June, which will introduce a new bundled payment mechanism that's being piloted in Western Australia in the private sector.
Yeah, so we've got our blue sky thinking at the moment, and we're really looking to bed down how we might implement such a payment system in terms of bundling or capitation. There's all sorts of things to figure out: how we would risk adjust the payments, inclusion and exclusion criteria, who bears the risk in terms of whether that bundled payment covers the cost of all of the services within it. So something we'd really like to work with states and territories on. We did have a go at designing a bundled price for maternity care back in 2016, and the report from that piece of work is available on IHPA's website. We really came up against a big implementation issue there in terms of the lack of a sort of nationally consistent, unique patient identifier that we would really need in order to look at the interactions between hospital and shared care. So we're looking to iron out some of those implementation issues by piloting with states and territories.
Okay, so I've got a question from the audience. There aren't many coming through. I urge you, I've got a bunch of my own that I can always just ask, but I hope that you can, think of things that you want to know in particular from today's session. So we've got this one today from the audience. So does IHPA, oh, sorry, now I've just lost the question. So it was really just reflecting on our assumptions that we make on the data and so forth, and how they reflect actual activity results. So have you been able to evaluate the relative accuracy of your assumptions against actual activity results? And I'm just thinking in general, but also the impact, the short-term impact and longer-term impact of COVID on activity, and how that the sort of the modelling that we undertook and the and the processes that we undertook to validate our assumptions on that might be relevant here.
Yeah, sure. So I can that one. So for example, one of the assumptions, which is listed in the determination, which is essentially says that hospitals will return to full capacity in the longer term. And so this was based on, both analysis of data and consultation with jurisdictions. And you can see at the end of the initial COVID pandemic onset, so there was the lockdown resulted in a big drop in activity, and then you could see activity climbing back up to those historical levels, and came very, very close to those levels before the next set of lockdowns was introduced. And so we are, we've got standard kind of activity monitoring processes in place, but we're, also looking to, develop more, a more targeted framework around evaluating those assumptions in particular. But there's also, states and territories are also well aware of these assumptions, and I'm sure will be more than, willing to provide their evaluation of their data against our assumptions. And so this is an ongoing conversation into the future about how we can, evaluate kind of ongoing activity as we collect it.
So this year we've got the introduction of pricing of mental health care services for activity-based funding. So in particular, how will specialised mental health care hospitals transition from block funding to activity-based funding using the Australian mental health care classification?
Yeah, so this is a really interesting question, and I'm excited about when we started looking at pricing a bit of mental health care. So I guess some of the history of it. So as part of the National Efficient Cost Determination, which determines a lot of our block funding amounts, there is block funding paid through the pool to the states for hospitals and services that are not suitable for activity-based funding for various reasons. And one of them's being not meeting some technical requirements, particularly around data collection or existing classifications. And so one of these groups is specialist mental health care facilities. And initially, I was hoping maybe, I'm not an expert in classifications or anything like that. I do pricing at IHPA. And I thought, oh, great, admitted mental health care classification. There's these specialist facilities, and we'll be able to price that mental health care more accurately than before. And maybe that means that won't be block funded anymore. So when we started looking at this and through our consultation, we actually found that those mental health care facilities are, I guess the area of specialty is not, covered by the admitted mental health care classification as it stands. And so that was maybe a bit of a pipe dream of mine, but at currently, there is no plan to be transitioning those to activity-based funding just yet.
Okay, so how do you assess the impact of COVID on the National Weighted Activity Units, or NWAU, and costs for patients who are not admitted for COVID as a primary or secondary diagnosis, but are found to be COVID positive, for example, extra PPE costs, etc.?
All right, so I'll take that one again. Sorry, this is a bit of I'm kind of stepping in. I'm more than happy for anyone else to jump in if they want. This one's pretty fresh in my mind though, so I'm more than happy to talk to it. Around the price setting we did, the latest EP and the modelling I spoke of to try and understand the cost of COVID. So this doesn't actually depend on there being a primary or secondary COVID diagnosis. So what the really key piece of work there was trying to understand the change in average cost for a patient during the COVID pandemic. So it's less about, a patient has COVID and therefore might have different costs associated with them, and more about, hospitals have changed their practice in a certain way. In the example in the question, related to PPE costs, and that these are one of the input costs that are recognised as part of that adjustment. So obviously, there's here's the typical average cost of an admitted acute patient historically, and that's been growing at roughly 2.6% per year for a long time, and then there's another significant jump up on top of that in setting the latest price to account for, okay, there is this sudden change in input costs to as a general a change in the way hospitals are operating and have those increased cost pressures.
I think, and just to add to that, I think one of the challenges for us is to sort of try and identify in consultation with all the jurisdictions about what are these sort of more permanent changes in the costs from sort of the temporary shocks that we saw. So, for example, the temporary shock of an area or a local geographic area being in lockdown, because there might be costs associated with that, which for future pricing may not be as relevant as the sort of more long-term shocks that we may have had.
I might just jump in there to give a little plug to the public sector cost report, which has recently been published on the IHPA website. And if people are interested in, so that's for the 19-20 financial year, so COVID impacts seen in the final quarter of that year. There's quite a bit of analysis in the cost report that splits out the impact of COVID and does some comparisons between the pre-COVID and post-COVID period. So that's referred to as the Round 24 National Hospital Cost Data Collection Public Report, and that's for 19-20, if anyone's interested in just seeing some of those initial cost impacts that we've seen. So Sam's talked a lot about how it impacts price setting, but if you'd just like to have a look at how it impacts the raw cost data, that's available on IHPA's website.
And so just going back to the earlier discussion about the potential future funding models that we touched on, and you mentioned, Sarah, on the work that we'd previously done on maternity bundling. So the question is, are you looking at revisiting this work on maternity bundling in the future?
Well, look, potentially. We're still grappling with that implementation roadblock that came across, and I guess this is a chance for another plug from me to say we're working really hard to get the individual healthcare identifier into the national data sets. That for a myriad of reasons, but that would be a huge step forward in being able to design a nationally consistent funding mechanism, whether it be a bundled price, a capitated price, crossovers with primary care, which is a big consideration, particularly for maternity bundling. So I think, look, if we were able to carry out a pilot on maternity care with a particular jurisdiction, LHN or hospital, where we could sort of test it with that jurisdiction or hospital's data that did have a consistent unique patient identifier, I think IHPA would be very open to that.
Yeah.
Yeah, just to add to that, I think, sorry.
Oh, well, I was just going to, because I sort of, you sort of addressed my next question, which was on data linkage, and I wanted to ask you, bring you in, Key. So I'm going to ask it first because I'm going to preempt what you're about to say, I feel. So it is on this same thing around future funding models, and in particular, are there any requirements to the national pricing model being considered to take advantage of an increased data linkage across the healthcare sector? So perhaps that's certainly what Sarah was touched on there, and I feel that this is one area of your expertise, in particular, Keys.
Right. Yeah, sure. Thanks, Dred. So yeah, absolutely. It's absolutely vital that we make use of that increased capacity to link data across the sectors. And just to finish up on what I was going to, it segues nicely what I was going to say to add to Sarah's comment, which is that that I think there is a group at the Commonwealth and state territory level which are looking at finding topics of clinical topics and to support, well, I suppose for bundle payment to support new models of care. And it is absolutely clear that the Commonwealth is interested in this, and the state and territories are very interested in this. And as soon as you do that, you of course have a need to be able to follow and track a patient across the different parts of hospital care and community care, and even perhaps private care as well. So now we have the capacity to link these data. There are some great examples of where these data have been linked, whether it's MBS, PBS, hospital, acute, non-acute, and even private health insurance. But I think there's still an enormous effort involved from both for both researchers or in government to try and get access and bring all those data links together. And we have in this country, we have various models around data linkage, starting from the WA experience where it was state-based, but they brought the Commonwealth into that with probabilistic matching. We have examples like the Women's Health Study or 45 and up, where it is people providing permission to have everything linked. And now we seem to be able to, there's some new legislation in place that allows some more linkage at an aggregate level. But we still have various models around, which makes access, I won't say impossible, but complex and costly to determine, both in terms of being able to provide that and doing that. But it is an absolutely essential roadblock or an essential piece of the architecture that you need if you want to look at payment reform.
Okay, so we've got a question here on the balance of best practice care versus funding. So how is this balance maintained? For example, if you're looking at bundled payments for hip replacement, and if the best practice is three follow-up rehab sessions over a certain number of weeks, but the hospital still gets the same payment if they only undertake one rehab session, is there any perverse incentives perhaps there at play, and how is that sort of balance between actual best practice managed against the backdrop of funding?
Shall I? Yeah.
I'm happy to take it, but I'll let someone else speak. So I think like the idea behind a bundled payment would be that it would be based on an identified best practice. It would be in consultation with clinicians, etc. In the example, if the best practice is to have 3 sessions and then a hospital only does 1, so on one hand, the idea is that it's for the hospital and those the clinical staff there to determine what's best for that patient. And so in that way, that's the flexibility I referred to within a bundled payment. On the other hand, as far as perverse incentives go to reduce care, I guess one of the advantages of the data linkage we were talking about and having all our prices set on are all evidence-based, based on actual cost and activity data that's reported to us that we link, means that, say, if hospitals started to do that, then the price of that bundle would go down and would only reflect a single service rather than the best practice of 3. So I guess it's, it was within, the hospital's best interest to provide the highest quality care, and then the prices will reflect what that costs.
Yeah. So just to add to that, I think it is essential that quality measurement is part of any bundle payment reform process to try and minimise the risk of skimping as such. But the other thing I'd say is that obviously where you're going to introduce bundled payment is also highly relevant here, because Australia's health system doesn't actually perform too badly. We do pretty well with with what we have and what we do and achieve with it. So it's not a matter of actually doing whole-scale, reform and changing everything that under the sun. What you want to do is look at the current system fail to support best practice care. And so there are some aspects, and Sarah mentioned this, is there are some aspects where we think the current system is volume driven, and where that volume may not be, in fact, what the model of care is really after. So it's not just about what it is that you're going to do, it's also about what you're trying to replace. And so to find the best alternative to that, to what you're trying to, where you think there's a problem and what you're trying to change around.
Yeah, it's a balance between giving quality, but also having enough quality measures in there to guard against perverse incentives. And I sound like a broken record, but that's something that through a pilot, we would be able to, go through the intricacies of that and try and iron out and come to a preferred approach on.
Yeah, so the question on safety and quality pricing. So has IHPA seen any improvements in the quality of care since the adjustments for avoidable hospital readmissions have been introduced?
So I'll take that one again. So the adjustments for avoidable hospital readmissions were introduced in NEP for the 2021-22 year. So we're only just collecting data now for the first year that was introduced. So the short answer is no, we're not seeing improvements yet, but that's not to say that we have the data and there's no evidence of improvements. It's that we don't have the data yet. It's too early to say.
We've got 1 quarter.
Yeah, we've got 3 months.
But Sarah, this is a great opportunity for you to plug the other aspect of the webinar, which is the National Benchmarking Portal.
Yeah, so that is something that, so obviously we are releasing the new National Benchmarking Portal next week. And the first tranche of dashboards in that National Benchmarking Portal focus on the cost per NWOW metric. But later this year, we'll be developing and releasing dashboards on hospital-acquired complication rates and also avoidable hospital readmission rates. So as that data gets updated, those raw and risk-adjusted rates for HACs and avoidable hospital readmissions will be available not only to us, but also to the general public, researchers, hospital managers to track those trends. A bit of a lag, not real-time reporting by any means, but definitely a lot more transparency in those rates coming up in the new National Benchmarking Portal by the end of this year.
Okay, so a question on block funding and the national efficient cost. Like this really applies to both the national efficient price and the national efficient cost, but I think it's potentially more pronounced in the case of national efficient cost, and that is, how does block funding under the national efficient cost for hospitals that have, how does block funding under the national efficient cost account for hospitals that have large changes in activity between the year in which the year of data on which the NEC is based and the year in which the national efficient cost applies? Because of course there's a lag between the actual year of the data and the implementation year of the national efficient cost.
Yeah, so I'll jump into that one as well. That's a pretty good question. So I guess the core of this comes from, I'll go back to the NEP and ABF. So the funding for the larger hospitals that get funded through ABF and the NHRA, they're funded based on their actual activity levels in a given year, and that's reconciled, by the National Health Funding Body, a separate agency, but they have the same data that we do and see the population activity, can apply our national efficient price determination, and say, this was the price for the activity as delivered in that year. The national efficient cost, and in particular block funding for small rural hospitals, is very different because there is no reconciliation process like that. And so for the NEC for the 2022-23 year, for example, we determined the efficient cost for those small rural hospitals based on 2019-20 data, and that's prospectively set, so that's forecast for 3 years into the future, and then that's it. There's no reconciliation once 2022-23 data is collected. It's predicted 3 years prior to that year actually happening, or predicted with a 3-year lag there. And so how do we account for when there's large changes in activity? And I'll answer that, but I think to motivate it, I'll answer a slightly different question first. Sorry. So we account for small changes in activity through the indexation methodology to forecast the NEC model parameters, so the block funding amounts. And you'll notice in the determination that the NEC indexation rate is always larger than the NEP indexation rate, and that's because it includes both the increase in unit prices as well as the increase in expected activity. So it's modelling that change in activity over time, and there is a general growth trend in the small rural hospitals. Where there are large changes that are wouldn't be captured by that indexation methodology, we actually collect this information directly from states and territories. So they advise us where there's been big changes, for example, where there's been natural disasters and activity has completely dropped off. But that won't be reflected in the data that we're looking at, but they, will require maybe a higher, the typical activity and throughput that they'd expect is much higher, and so the hospital is inoperable on, the payment that would be made based on the data reported in a given year. So, if they had no activity because they had to close for 6 months, any payments relating to that wouldn't be enough to keep a larger regional hospital open. So, this is through state consultation. They give us this information and we figure out something that works for them.
Okay. So I've got a couple of questions about the mechanics of the actual the funding model, the prices and so forth. So first, and this is like a bit of terminology, right? So first of all, what is a hospital's cost profile, perhaps, Sam? And then second of all, does IHPA make any adjustments for payments to states that have an average cost lower than the NEP?
Sure. So this might be a question that was referring to the pre-recorded presentation. So that was around looking at, so this was in terms of development efficient price, we seek to understand the cost profile of not so much of particular hospitals, but of particular services. So for example, a diagnosis from, and I guess that cost profile would be looking at how does the cost vary with length of stay is in its simplest form, and that would be what I'd call the cost profile. How does that look at, how does that vary between hospitals and around the country, indeed different geographic regions and under different patient cohorts. That's where we kind of transition from calling it a cost profile to a price profile, or the price, to try and so that we can account for that unavoidable cost variation you see around the country. So I hope that answers the question for whoever asked that. The second question was around, are there state-specific adjustments for states that have a price different to the NEP? So no, there isn't, not from IHPA's work. So, IHPA's tasked under the National Health Reform Agreement with setting a national price, so it has to be nationally consistent. So we do just set a single national price, and I think it's important to understand here that the prices that IHPA sets informs the Commonwealth contribution to hospital funding. So there's another agency, the National Health Funding Body, which take our prices, apply it to activity, make sure that's all correct, go through processes they have in place to advise the Treasury to make payments based on hospital activity. And so that forms 40 to 50% of public hospital funding, and then states have their own state price, and they can choose to pay at a higher or lower price than the national efficient price. And so IHPA sets the national efficient price. If a state decides to have a much lower efficient price than the national one, so that's a risk that the state takes on in that instance.
Yeah, and some states and territories might start with the IHPA model and make state-specific changes to particular adjustments, or not pass on particular adjustments, and that's really up to each state and territory to determine the state contribution however they see fit.
Yeah. So a question, another sort of question on the fundamentals of IHPA's work program. So, and perhaps this one was, could have been addressed by Joanne, who introduced the session, who's Executive Director of the Classifications Branch. But how does IHPA consider surgical procedures which can have significant effects on the costs, or DRG costs and so forth, and how they picked up? And if they aren't picked up, how are those sort of things accounted for and refined over time? And the example, the example given is a high-value prostheses device that's used in a particular procedure.
Yeah, so I guess my response to that would be, I guess, like Sarah or Keys might know more about this, but I guess coming from, like how prices are set. So, it's a national price. It's based on typical, service provision. And so we're, at a DRG level. So the pricing model, returns the cost of that DRG. So that's to say that the price assigned in total for the total volume within a given DRG will be equal to the costs reported for that DRG. So that would include high-value prostheses items. They're part of the public hospital pricing model. And if there's thousands of these surgical procedures, but only some of them use a particularly high-value prostheses item, then that won't have a very big impact on the individual unit price, but overall that cost will be returned. And so it would increase the cost marginally. So the episodes which don't use that particular high-value item, on average would be paid a little bit more than the cost, whereas the ones that do use that item would be paid a bit less. If it's a particular item or a technology that is, considered, is used more extensively, then that would, ultimately be reflected in the price. And, as the third option, where there is particular technology in use that is not recognised by the pricing models, and where this is, isn't recognised within the classification or the existing pricing model, but affects a significant number of patients and has a large cost impact. That's when we start to introduce these adjustments for a legitimate and unavoidable variation in cost across the country. So I guess that's a couple of answers to that question for different scenarios.
Yeah, I guess just going one step back, if it's the only reason why it wouldn't be, why that cost wouldn't have some impact on price setting is if it isn't reported to the general ledger of the hospital and submitted through the National Hospital Cost Data Collection. It needs to be reported through the NHCDC in order to inform the price. So if for any reason those costs aren't flowing through, then it wouldn't be incorporated into the price. But if that's all flowing through, then everything that Sam said applies.
And I think actually that's a really good point, Sarah. So just touching on, just taking that a bit further as well. And it's not just about reporting on it and having it flowed through, but it's also comes down to hospital costing processes as well. So making sure those costs are allocated to patients, as accurately as possible, because that's the data we use to try and recognise that cost pressure when we're setting the price.
Yeah, and I'd just also add, from a classification perspective, the DRG classification has there's a ongoing refinement process that supports the DRG classification, and the way in which the DRG classification is structured. The sort of half of it is the intervention partition, and the other half is the medical partition. And the intervention partition is primarily classified based upon the interventions undertaken within the episodes of care, and there's principles that are maintained and applied in the classification development, which go to the actual clinical meaningfulness of these DRGN classes. And so if there are particular DRGs that, it really comes down to an actual classification refinement question as well. Like, are these particular procedures that include that are associated with these high value prostheses device, used to identify episodes of care within the intervention partition? If they're not, perhaps they should be. If they are, but they need to be refined and treated separately within the intervention partition. These are sort of questions around the actual refinement of the DRG classification. And so IHPA has these ongoing consultation processes associated to that refinement, and that would be another way in which these sort of adjustments could be brought about if they are evaluated as being appropriate. So on back to the national benchmarking portal, Sarah. So is the national benchmarking portal just on public hospitals, or is there any private hospital data in there relating to HACs and avoidable readmissions, as they relate to as they may be available in the public system?
So as per the remit of IHPA, it's all about public hospitals, but it will include information on private patients in public hospitals. But yeah, at the moment, it will just be public hospitals. I am aware of some work being undertaken by the Australian Commission on Healthcare, who are also developing some public reporting on HAC rates, and I think they will have both public and private hospital comparisons in there, or at least rates in both private and public hospitals. But yeah, just public hospitals for the national benchmarking portal.
And so just on the impact of COVID in terms of our work program, a question on that. So how will IHPA assess when to continue with other refinements to the national pricing model that perhaps were previously progressed and then deferred due to COVID-19, such as the non-admitted care costing study?
So I guess I feel like there's two questions there. So one was around refinements to pricing models, and there were, so some work we were doing around trying to understand the cost differences for similar services delivered in different settings, so around, say, price harmonisation. And obviously, the onset of COVID meant that, there's minor kind of, not minor, but, less crucial pricing model refinements that were deferred while we, allocated our resources to try and understand the impact of COVID as deeply as possible. And I guess in answer to that, it's more around, would we keep looking at the data and to analyse and understand what's happening, and when we start to see, some of those impacts of COVID as they're reduced a little bit and we see a little bit more stability and consistency in the data, then we can start looking at some of those more kind of longer term adjustments where the data might be a bit volatile at the moment. I guess the other question, say around the non-admitted care costing study. So this was, kicked off to inform classification development in the non-admitted setting. And I mean, I'm not heavily involved in that. I can't speak to when it might kick off or what the plans are there, but I'd say a broadly similar response in terms of, as hospitals start to open up again and have the resources available to assist in a costing study like that, is when we'll really be able to get back into that work program.
Yeah, I think it's still just a bit of a watch this space.
Okay, so I might. Oh, sorry.
Sorry, you go.
No, I'm sorry, Sarah. No. Just sort of briefly, we're almost at time. So we touched on these things earlier on, but basically in terms of the hospital ledger and the costing process, the question is, does the ABF cover non-MBS items? If not, how can non-MBS items get funded in public hospitals?
So I guess tied to it as part of your asking of the question, Trent. So with the national data collections and cost data collections, essentially ABF covers, there's a defined in-scope cost, which is essentially the complete cost of care, but it does exclude anything that's already paid for by other sources of funding or Commonwealth programs. So examples are the Pharmaceutical Benefit Scheme or blood products, which are funded through separate programs. So there are some costs excluded, capital costs, depreciation, that kind of thing. But apart from that, it's the complete, the total cost of care, which goes into setting the national prices.
Okay, well, that's all we have time for today. Thank you for joining us this afternoon, and to our panelists for sharing their knowledge and experience in this important area. I hope you found the session useful. Please stay online as a short survey will appear on your screen, and we'll appreciate your feedback on the session just after the session ends. Thank you. I hope you'll be able to join us for the last session of the Q&A webinar series. In June, we will take an insightful look into policy development relating to innovative funding models. You can find out more on our website, IHPA.gov.au/events. We look forward to seeing you at our next IHPA event. Bye for now.